Spotting a stroke can be tough, even if you know the common warning signs. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Lori Finnerty suffered a stroke that could have drastically changed her life. She admits she thought she was dying, but she credits her husband for noticing something was wrong and calling 911 quickly. Thankfully, doctors were able to reach into her head and remove the blood clot that was starving her brain of oxygen. But recovering from a stroke like that can take months, if not years. Before we meet Lori, though, and some of the care team that took care of her, let's get to our morning rounds on this Monday. The University of Kansas Health System has some new gear that can shield staff from radiation. Dr. Alan Reeves is here to help us explain. He is the Director of Interventional Neuroradiology here at the health system. Dr. Reeves, good morning.
Good morning.
Good to have you. So before we talk about these new shields, just explain to folks what an interventional radiologist does and how that involves radiation.
Sure. Interventional radiology is the field of minimally invasive surgery and procedures that's guided by imaging. For the most part, that imaging is using x-rays, powerful x-rays called fluoroscopy. And in my world, we work with actually powerful imaging called biplane fluoroscopy. So it's actually two sets of x-rays that simultaneously image the brain mostly, but other parts of the body as well.
All right, so let's take a peek inside your world because we have some video of you at work. And in the past, underneath that blue gown, you wear a lead gown. What was that like? What has that been like? How heavy is it? Kind of explain that.
Sure. So that's critical for protection against the ionizing radiation. And these lead systems that we wear, they're divided into two pieces, three pieces sometimes, and they can weigh up to 25 pounds, sometimes even more. So if you're going to be doing a procedure or a long surgery in the suite, then you're going to have to put on lead to protect yourself from radiation. So radiation is great for what we do. It helps us see everything we need to see, but there are downsides to radiation that are very significant, and so we have to protect ourselves.
Absolutely. So let's show these new shields. They can block the radiation, and it's actually as good as lead. So what has it been like working with the shields now instead of those heavier lead gowns?
Well, it's great. So the shields aren't perfect for every case, but on the cases that we can use them, we're actually getting better protection from radiation than if we were standing there wearing our lead gowns. So the shielding is about 1 millimeter thick for lead, and when we're actually wearing our gowns, it's only about half of that. So the shielding basically creates a box around the x-rays and prevents those x-rays from getting out into the room. Most of the x-rays that we're exposed to is the result of something called scatter. So the x-rays hit the patient, and then some of those x-rays go into the image intensifier or the flat panel detector, and that's what we see, but a lot of those x-rays then get bounced around the room. So that shielding helps protect the scatter from the patient, and really it protects everyone in the room much better than if we were just wearing lead.
So, I mean, we know putting our patient safety, that's always front of mind when we're caring for our patients, but also taking care of our staff, our doctors, our nurses, and folks in those rooms, very, very important. So what do you think that long-term benefit to your health will be?
Well, there's no question about it that exposure to radiation can lead to cancer. So there are certain types of cancers that are directly related to long-term exposure to radiation. We try to protect ourselves as much as we can, but it's part of our job to use radiation every day. Cataracts in your eyes, those are accelerated in people that are exposed to radiation. And then orthopedic injuries, it's estimated that 60% of people that wear lead at some point are going to develop back problems. That's a lot. I mean, that's for me, my techs, the nurses, everyone in the room has to wear lead. So if you can mitigate those problems, then you're going to be much better suited to help the patient, actually. And then finally, it's exhausting wearing lead. So if you get into a 3, 4, 5-hour case and you're wearing lead, it is exhausting to do that.
Right.
So anything we can do to help mitigate those issues, we're going to do it.
Well, Dr. Reeves, always good to see you. Thank you for sharing, and keep playing it safe.
Thank you.
Thanks so much. Well, in the past, treating a stroke boiled down to giving a patient a clot-busting drug and then waiting. But today, a modern technique lets doctors take a much more active role in the treatment of strokes. And we are happy to have one of our patients joining us, Lori Finnerty. She's with us, and she survived a stroke thanks to a whole slew of people who worked to save her. Dr. Ebersol, one of those folks with us. Lori, good to see you. Jamie, I'll get to you in one moment. Dr. Ebersol is a neurosurgeon who actually pulled the clot out of Lori's brain. He is also the director of endovascular neurosurgery here at the University of Kansas Health System. And while Lori survived, she needed quite a bit of help learning how to speak again. We hear about that a lot with stroke patients. And so we have Jamie Johnson joining us. She is a speech language pathologist, a hugely important role in stroke recovery. So Jamie, Lori, Dr. Ebersol, welcome. Good to see you. Good to see you. Lori, though, let's start with you. Take us back to January 2022. The morning of your stroke. How did your husband play a role in recognizing that something was wrong?
We have the fast magnet on a refrigerator. We have for years. And he came back and I was in the shower for a long time, just standing there, and I just got out of the shower and went to the closet, tried to put a sweater on.
Without
Sounds
drying off?
crazy, yes. So he came in and he came back to the closet and he said, "What are you doing?" And I could hear him, I could see everything, but I really didn't know what I was doing. And he said, "Sit down," and he called 911.
Which is key, right, Dr. Ebersol?
Yeah.
Oh, absolutely.
Recognizing and then making
For
that phone call
Yes.
so we can get to you as quickly as possible. Lori, if you can remember, though, maybe in more detail, just what was going through your mind? You said you could hear him, see him, but you didn't know that anything was out of sorts.
Well, I knew something was wrong because when I first woke up, I was looking at the TV and the Hulu sign was just going around and around. And instead of doing anything about it, I just laid there and stared at it. So finally, I did get up and got in the shower, but I knew something was wrong, but I wasn't worried or upset or anything like that. I just was doing it's so funny, I was thinking about that, and I thought every day I get up and I take a shower and I get ready for work, and that's what I was doing.
You were
I was doing a routine
Yeah.
without really realizing that something was terribly wrong.
Something that we do
I
every
didn't
day.
even use shampoo or anything. I just stood under the water.
Well, something though
It's
that
very odd.
very odd, but something though that you did that was very smart, and you mentioned the Be Fast magnet that you and
Yes.
your husband have on
Yes.
your refrigerator, and we want to use this moment to share what that is, the most common signs of stroke. Just please remember Be Fast. Here's what it is. All of these could be a sign of stroke. Balance changes, eyesight problems, face drooping, arms that can't be raised, speech problems, and finally, as we've mentioned, the most important is time. Time is of the essence. It is time to call 911, just like Lori's husband did. But in this case, Lori, your symptoms didn't necessarily match one of those warning signs. Dr. Ebersol, I want to ask you, does that mean that there's other symptoms outside of Be Fast? We talk about that. It's so important. But how do we know then? How do we?
I agree. I think the whole point of that public health campaign is to pick up the signs for the most common strokes that can have an impact that would be life-changing. So it is impossible to try to memorize a set of facts for the general public that would describe every variety of strokes. So yes, the Be Fast that you have on your magnet is very much narrowed to the most common life-changing stroke that if we act fast, we can alter.
I love that, though, that they said they had that, and he really did
Yes.
exactly what it said. And Be Fast is a good starting point, just to start looking at those most common signs.
The one thing that I did have in that was the speech.
The speech.
I was not talking at all. I didn't realize that I couldn't talk, but he did.
Do
He
you talk
said
a lot?
I
Do you
did.
talk a lot, Lori? Is that what your husband's trying to say?
Yes.
You're not speaking. What's going on?
Yes, so that was one.
And that's such a benefit, again, a partner looking out for another partner and knowing your routine and knowing what you do every morning. Dr. Ebersol, you have shared some images showing what was actually happening in Lori's
Sure.
brain this whole time. Just walk us through this, show us what we're seeing.
Right. So, Lori, these are your actual images from your hospital stay. The first thing that we do if you come in and we're suspecting a stroke is you have to have a CAT scan because a number of processes that happen in the brain can lead to the same set of symptoms. So importantly, your CAT scan was nearly normal, which is what you're hoping to see, because that means that the diagnosis is an ischemic stroke, meaning a blockage of a blood vessel, and that the changes that the brain are experiencing are not permanent. We have a chance to reverse them. So then this image is dye injected into the CAT scan, and we're looking at your blood vessels. And an AI algorithm will reconstruct the blood vessels and give them this snapshot view. And you can tell, even if you're not a brain surgeon, that there is a blood vessel that's missing from the right half of this screen, which actually is the left side of your brain. Whenever we're looking at images, it's though the doctor is looking at the patient face to face, so the images are opposite. But there's an obstruction there that will change your life. That green territory is another specialized scan that we have here that tells us how much of the brain is at risk. That is nearly half of the brain, and it's the dominant hemisphere, the one that's responsible for language, and then motor and sensory, meaning your ability to move and feel on the right side of your body, is predicted by this scan to be completely lost. So you went immediately to the endovascular sweep, the same place that Dr. Reeves was describing in our pictures behind the lead shielding, and we can see the exact obstruction when we inject our dye. So we need to get there with our instruments and open that blood vessel back up. The instrument that we used, it's kind of like a very long soda straw, if you can think about that. If I was taking this soda straw and sticking it into Jamie's glass and trying to suction from here, I might be able to remove an obstruction. The difference is it's much more sophisticated because it has to travel. It's about 3.5 feet long from an artery in your leg through the anatomy of your abdomen and your torso, up the neck, and then into the brain without kinking, collapsing, traumatizing the instruments, and then take it right to the face of the obstruction and apply an aspiration force, which is essentially a vacuum pump, and we're trying to suction the obstruction out. And sometimes it comes right out onto the table, and you can see it, and then when you take the next picture, it looks like this. All of that blood flow is restored to that half of the brain. It probably took the anesthesia team longer to have you safe under anesthesia than it did to take this obstruction out.
Lori, I know you're in awe because you've never seen these before. I bet you're pretty glad you're in the hands of Dr. Ebersol when you hear him explain all this to you.
Absolutely.
He knows what he's doing. And when you saw him this morning, did you recognize him?
No.
Tell us why that is, Dr. Ebersol.
Yeah, I can't.
It's an interesting phenomenon about the brain when it's in an emergency. But the brain is using all of its resources to recover from this, and it's not using any extra energy to store short-term memories. So it is not uncommon for my patients that encounter me in an emergency setting, because that's what my practice is, and not remember many of the details of the hospital stay. And we really get to meet each other well afterwards, after the recovery of the brain has taken place. So that's what happened this morning. We essentially met each other.
And met each other in real time, in real life. What was it like?
I'm so grateful. Thank you so much.
Okay, I want to talk though about this technique of clot removal. This EVT, it's called an endovascular thrombectomy. A big word, explain that.
That is the approach of using minimally invasive instruments under X-ray imaging, like Dr. Reeves was describing, to go to the blood vessels of the brain and remove an obstruction. We've been doing this for over a decade, but it really changed the face of stroke management in 2015 when a trial out of New Zealand showed that if you do this and you do it early enough on the right patients, you can improve their outcomes in a dramatic way. It had changed what was the standard of care for 20 years prior to that. So yes, it's using long, flexible, safe instruments to remove something way up here from way down here.
A really exciting time, I would imagine, in your field.
Yes,
for you to
absolutely.
show up at work every day. Because
Yes,
when
yes.
I called you and asked you to join us on this program and that Lori was going to be here, you're like, oh, absolutely.
Yeah.
Absolutely. You were just so fascinated by Lori's case, and it must be a thrill to see her sitting here doing well.
That's outstanding. I mean, these are the types of things that we hope for. It's a tremendous system-wide organization to be able to do these things, to identify the patients quickly who are having the diagnosis and who have a chance for reversal of that process. So every step of the way, from the magnet on your refrigerator to your husband recognizing these things, knowing he needs to call 911, the emergency team in the ambulance knowing they got to get to KU with the lights flashing, and when you arrive here, the emergency room already prepared for you, the stroke team activated, everybody's on board, and by the time you're upstairs, everything is all set for us to deliver the therapy.
almost the perfect case scenario
Oh, I
across
agree.
the board,
I
starting with
agree.
that magnet on the
Yeah.
refrigerator. I like how you mentioned that. And we know that removing the clot, of course, is one thing, but many patients will spend weeks, months, even years recovering. Lori, you didn't recognize Dr. Ebersol this morning, but one person you did recognize was
Yes.
Jamie, of course, because she helped you through your speech therapy. Talk to us a little bit about aphasia, what that's like, and is that what Lori was experiencing?
It is. When patients have involvement in the left side of the brain, for most of us, that's where our language is. So she had difficulty getting words out, understanding words, and then eventually we figured out reading and writing as well. So those are the areas that we really look at and evaluate when someone's had involvement in that area.
So is that pretty common for all stroke patients? What are some other areas in which you help them? What are some different scenarios in which you've helped people get back to life?
So one instance might also be for swallowing. Lori had a swallowing evaluation while she was an inpatient by her inpatient speech therapist, and she did well with that, so she was able to eat and drink. Beyond just language, we also look at memory, cognition on the other side of the brain, and we also look at speech and how her speech sounds. That's the first thing people will say to us, well, my speech is fine. It's not always the speech that you might be able to see, it's also the language.
So do patients recover from aphasia just on its own, or does it have to take some sort of therapy to really recover properly?
That's the great thing about our brain, neuroplasticity. We're able to heal a lot of that, but hopefully with therapies, we're able to aid that and get more benefit or more bang for her buck and getting her speech and language back so she could return to work.
So Dr. Ebersol, take us back inside the brain. What we hear speech and stroke connected, but what's actually happening and why is that stroke affecting our speaking mechanism?
Right. So remember, the whole point of your body moving blood around is to deliver oxygen to the tissues for them to carry out their tasks.
Mm-hmm.
So if you have an obstruction in a major blood vessel in the brain, everything that's supplied by that blood vessel is not getting enough oxygen. So the brain is experiencing dysfunction. So if that area happens to be speech, your speech will not be working correctly. And if in a timely manner we can restore blood flow, now the brain can have a chance to restore that function. So a lot of function can come back suddenly, but the protracted effort over time is what makes the outcome better and better the more effort you apply.
I love it when you're here to explain things to me. You always explain it perfectly. Okay, so Jamie said that she helped Lori get back to work. How is being back to work for you? What adjustments have you had to make?
Well, as we talked about, and she helped me through it, that was probably the best thing that I did. I went right back to work. I think I was back to work in 9 days. And as there's no way that I would have been able to do that without therapy.
So you get back 9 days later. What were some things you were doing? You were working from home, and you said you were taking a lot of notes.
I do talk to, I'm a paralegal, so I do have to have a lot of phone communication with attorneys. I also do a lot of typing, but everything is language and words, and I have to send a ton of emails every day. And so that was a challenge.
But Jamie, is that good for her?
It was really good for her, but we wanted them to be correct.
Well, and that's what you said. You said, tell me about when you said you just try to find other words.
Yes, I had the biggest thing when I went back and thought about it, I would have missing words in a phrase. And I wish I could think of a phrase right now, but I would have missing words. Or there was a simple word like minute, and I would say minute. I would mispronounce a lot of words. And Jamie can tell you more about this than I can.
And that just gets better over time?
It was very difficult.
Yeah, and you think she's, on the phone, she's getting a voicemail, she's reading an email, she's sending an email, she's talking to someone all at the same time, things that we take for granted.
Right.
And if your language isn't working, that makes it really hard.
Accuracy is key.
Yes.
It is key.
When you're doing your job.
Details and accuracy is
Correct.
And so is her reputation. She had a long-standing reputation of being very good at her job, and we wanted her to be back at that.
Back to where she was. Okay, something very cool though that happened to you. You got a special opportunity out at Kauffman Stadium. Let's take a look at that.
Sitting in the Buck O'Neil Legacy seat tonight is Lori Finnerty. Lori is a stroke survivor who was treated at the University of Kansas Health System's Comprehensive Stroke Center.
Okay, not a bad experience, Lori. Tell us what that was like to get that honor.
I was so honored by that. I'm a sports freak anyway. And I knew about Buck O'Neill, and I read more about him when I got the honor. And we share a birthday.
Really?
We have the same birthday, and that's my daughter or stepdaughter Lauren and my son David. And my family is fantastic. And just to be in Royal Stadium, and my son's friends went. And it was very, very special to me.
A big full circle moment,
Yes.
celebrating where you'd come. And I was seeing those pictures of your family. How important has the support been with family and friends?
110%. Just, yes. Everybody's been very supportive, very, very wonderful. My family's wonderful. And these two here, I could never thank enough.
Well, if you have any questions about stroke or speech therapy, use the chat on YouTube or Facebook. You can tweet us or email the Medical News Network. The info is right there on your screen. Right now, let's get a quick check on our COVID count. Dr. Dana Hawkinson joining us. How are you this morning? Happy Monday.
I'm good. Yeah, happy Monday. I rode the scooter in. But,
You did? You did? You rode the scooter, no rain?
I looked at the iPhone weather and it said it was clear.
Okay, you made it
It was
in-
clear when I made it in.
In the
but-
nick of time.
Yeah.
What's going on?
Nothing. Numbers still good, but not as good as they used to be. Last week, we have 9 total. Unfortunately, 6 active. 0 in the ICU and 0 on the ventilator. So again, still under 10. We're happy about that. If we could push it further down to 0, that'd be a lot better.
It would. All right.
Yeah.
Feeling a little bit of deja vu with a few headlines that we've been seeing about this so-called triple-demic. We talked about that last year, the CDC preparing for a winter of COVID flu.
Yeah.
And then the COVID, the flu, the RSV. We talked about this last year. Some concerned that the 3 different bugs could put extra stress on hospitals. Are you seeing that? Are we predicting that? Are we prepared for that? Where are we at?
It's hard to tell. I think let's start with COVID. We know there's always going to be circulation right now. Right now there's low circulation of the virus. We do expect higher circulation in those colder months, but this has really started to become a disease process of those people that are highest risk. So age, comorbid conditions, chronic issues, especially immunosuppression, things like that. We know RSV, again, tends to affect more of the very young and the very old, but luckily we have some products coming out now, some preventive products to help prevent those hospitalizations and those severe illness in those highest risk patients, both for very young babies and also the elderly. So that is a good thing. And then, of course, influenza. And we always talk about we are either preparing for influenza season, we're in influenza season, or just coming out of it and getting ready to prepare for it again. We know that most recently the coverage and the efficacy of the vaccine has helped. Those people that do get vaccine, even if the match is not perfect, really continue to have a lower risk of hospitalization and severe disease. So I know people are fatigued by hearing about these infections, fatigued about hearing about vaccination, but vaccination continues to be our best weapon to help prevent and lower your risk, your individual risk of going to the hospital, of having that severe disease. And that is true for all of these illnesses as well, especially if you're in those highest risk groups. So I think we should look at it more with optimism this year and moving forward, because we know the science continues to move forward, the medicine continues to move forward as well. So yes, we need to prepare for that and be ready for that, and we certainly are, but we also have these things at our disposal to help reduce your individual risk or one of your loved ones' individual risk of severe disease as well.
Great message this morning. Dr. Hawkinson, thanks so much. Any reporters with us today? All right, let's get to some community questions. Tim wants to know, Dr. Ebersol, do we know what caused Lori's blood clot? Do we know that after you're done investigating?
That is an important part of the hospital stay. So the first moments are making the diagnosis and active treatment. So all of that was done with an emergency time frame. But then thereafter, the workup is to try to understand why this happened in the first place. And for most patients, you can find an explanation where there was an abnormal rhythm in the heart and a clot was building up there and it traveled to the brain, is an example. Or you have cholesterol built up on the blood vessels of the neck, is an example. Combination of high blood pressure, cholesterol, diabetes, these are medical conditions that can add up to wear and tear on your blood vessels and you can develop a stroke. Actually, for Lori's case, they could not identify why she experienced this. She was in good health.
That was my next question.
Yeah.
How had your health been up until then? And also, what kind of changes have you made since the stroke?
Well, I quit smoking. I was a smoker, and I quit smoking. And I'm trying to think, my diet. I was a fast foodie.
Okay.
I think that's probably, to me, that probably really hurt me. I don't know how, but I do know that I feel a lot better, and I'm not. I'd love to say that I am only Mediterranean diet, which I've tried, but I do try to eat more vegetables, less fat, and a little more exercise. I did not exercise. So I think those are probably key for me, was the diet, the smoking, and the food.
That's all music
And
to
the
Dr. Everson.
It sure is. I can't believe it's the
Hello.
perfect
I'm not
patient.
100%, but I'm trying.
That's outstanding.
It's great when you meet a patient though who never smoked and always was Mediterranean, but I just, it's like hats off to people who are able to make that
I
switch.
agree.
Quitting smoking, one of the toughest things
Yes.
you'll ever hear about people doing.
Yes.
Getting out of that fast food line and just making those little subtle changes. So congrats to that.
Outstanding.
Thank you.
Pauline wants to know, Jamie, jump in on this, but what's the hardest part of speech therapy? Tell us what your hardest part is and maybe what other people struggle with.
My most frustrating thing, as she knows, was not being able to come up with the word. The word, anytime in a joke, a phrase. I wish I could think of one right now, but those anecdotes that you tell, or
Yeah.
you're just talking and you can't think of that one word. It's very frustrating.
How do you help people through that? Because again, you talked about it. What we take for granted just rolls off our tongue every day.
Yes,
but
it does. So we work a lot on different ways of coming up with words. We did it in the therapy room. We did it walking and talking, because that's how we communicate. Those are the real life situations. We work on synonyms and antonyms and ways to come up quicker and easier with words. The other part of that, which I feel like is hard as well, is when people don't understand. So if you don't understand what people are saying to you, then that makes it really hard to work on getting the words out or anything.
I bet this team right here between you two, it's like patience is the key, right? Just being patient and letting
Not frustrated.
And not frustrated. Lori, that's okay. We get it. We get it. Is it ever too late for a thrombectomy to get in there and do what you do?
Yeah. The maximal benefit will be as early as possible, because you're trying to restore blood flow to an area of the brain that has not yet permanently lost its viability. So the longer that the brain is without oxygen, the more likely that it is that those cells die permanently. So even if you restore the blood flow, it will not have improvement in function. So the maximal benefit is early, but we're stretching out what kind of benefit patients can achieve over long time frames. Important clinical trials that have been published in the most important medical journals in the world, KU has been a part of, and they have moved the timeline. It used to be that your therapy was only applicable to patients up to 6 hours, but we were involved in a clinical trial that moved it out to 24 hours. Now there's a clinical trial that shows that even if patients have an important volume of permanently lost tissue, they still have a benefit, because restoring blood flow has secondary benefits. So how late is too late? It's still being determined.
Well, it is case to case, I would imagine.
I agree. That's why it takes a network to make the call about when's the right thing to do, because it is an intervention into the blood vessels of the brain. It is possible to make trouble that can be important. You have to know that there's room for benefit there.
And minutes matter. I mean, the
For
difference
sure.
between 2 or 3 minutes, 10, 15
Absolutely.
minutes. Yeah, so case by case. Kim wants to know, how long after a stroke can you have side effects? Could this be lifelong? Speech and other things.
Yes. This is speaking to the severity of a stroke. For example, if Lori's husband did not recognize that these signs were stroke, her outcome could not be what we're seeing. It's every minute that passes, the brain is losing cells, and when you lose a certain percentage, it doesn't matter how hard you try afterwards, there's going to be permanent changes to function.
Last questions from Yen Liang. Arterial thrombectomy and the drugs that are used intravenously to administer those are two current methods used for removing blood clots. Which one is better, and do they have specific indications? Arterial thrombectomy and those and the
Yeah, thrombolytic.
I don't, Yen Liang knows not to give me, always great questions, but that's a big Monday word.
Yes.
So 2 types of current methods. Which
Yes.
one's better and how do you know?
There's no better here. These are both valuable therapies in the setting of stroke. In fact, having one does not preclude the other. We often use both if the patient meets the criteria for each of those therapies individually. So the intravenous thrombolytic means that through the vein, through an IV, you can be administered a medicine that will circulate throughout the body and it will eat up clots.
Okay.
So if you have a blood clot obstructing a vessel, this circulating medicine will concentrate its effort there and potentially at a chemical level resorb, break down the blood clot, and reestablish flow through the vessel. This is a proven therapy that we've been doing for nearly 25 years at this point, and it had been the standard of care for 20 years until thrombectomy proved its role. Thrombectomy is valuable for removal of obstructions in large vessels. The vessel needs to be big enough that it warrants the risk of delivering an instrument into the brain's blood vessels. That is the role for thrombectomy, physically removing it, because the IV thrombolytic, that circulating clot-busting medicine, is unlikely to open an occlusion in a very large vessel. So we use both of these independently because the obstruction, mechanically removed, can be further supported by this clot-busting medicine circulating around, opening up tiny blood vessels that may additionally be involved. Both of these things work together. And there's very specific indications for each one of these therapies.
You know your stuff. After all of that being said, what do you want the one takeaway to be today?
I think be fast.
Be fast.
That is critically important, but if I can add a second one, after the fact, do all of the things that Lori did. It's just unbelievable that you took all of those things to heart. Hard things that you had become your daily life. You said, I'm going to change these things for the betterment of my health. It's absolutely true. The single most important things that you can do personally, you did them all.
Well, and it is. It's being a good patient in the hospital, and then once you leave, it's going to your therapy and being diligent about that. Jamie, what do you want the final thought and today's takeaway to be?
So I think the takeaway from a speech standpoint, of course, if you have speech language or someone you know or a family member has this, it's important to get that therapy and to participate. It may not always be as great as Lori has seen, but there's still room for improvement. And Lori's the reason, and I think Dr. Ebersol would agree, that we come to work every day.
Absolutely. She gives people a lot of hope. So, Lori, what do you want the takeaway from your story to be?
If someone saves your life, make it worth it.
Well said. Thank you for being here with us today.
Thank you.
We appreciate you so much for sharing your story. Thanks to all of our viewers for being with us today and, of course, your questions. And yes, we do want to remind everyone to be fast when it comes to stroke. Screenshot that, look at it, put it on your refrigerator. It could save a life. Have a great day. We'll see you back here Wednesday. Coming up Wednesday on Open Mics with Dr. Stites. COVID can hurt more than your lungs. Emerging evidence suggests problems may persist in the gut. I'm Jessica Lovell. On the next Open Mics with Dr. Stites, we explore gut-brain interactions where problems can occur long after a virus or bacteria is gone. That's Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.